I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. In the bad old times before HAART, chronic diarrhea, defined as lasting more than 1 month, was more the rule than the exception. In this study from the Swiss HIV cohort, nearly 2,000 patients were followed for 2 years and 560 episodes of diarrhea investigated. Despite best efforts, the etiology was established in only about 1/6 of episodes of acute diarrhea and in a little less than half of the episodes of chronic diarrhea. This graph is a Kaplan-Meier plot of the occurrence of diarrhea lasting more than 1 month, with the x-axis showing time elapsed and the y-axis showing the probability. As expected, the likelihood of suffering from chronic diarrhea varies with the CD4 count. After 2 years, more than half of the patients in the lowest CD4 stratum had diarrhea. Parasites were the most frequent identified cause, with Cryptosporidium in first place, followed by Microsporidium, Giardia lamblia, also called Giardia intestinalis, Amoebus, and Cycloisospora belli. Among bacteria, we have Campylobacter, Clostridium difficile, and Salmonella. Generalized infections with mycobacteria other than tuberculosis, MOTT, were frequent. Infections with MOT and CMV are treated in other videos of this series. Chronic diarrhea often had dramatic effects on the quality of life, with malabsorption and massive weight loss. The depicted patient was a hemophiliac infected in 1980. He developed incoercible diarrhea due to cryptosporidiasis and CMV colitis and died in 1992. Let's now turn to cryptosporidiasis. C. parvum is a frequent cause of benign diarrhea in immunocompetent hosts. It is of importance in veterinary medicine. It infects children in warm climates, and it can cause massive epidemics through contamination of the water supply. For instance, in Milwaukee, Wisconsin in 1993, with several 100,000 of cases. In AIDS, chronic diarrhea caused by C. parvum can be very severe. At least 20 different treatments have been tried to no great effect. Only highly active antiretroviral therapy was effective. Here we have different aspects of C. parvum in feces. The scanning electron microscope shows spheres of approximately 5 microns in diameter. In clinical practice, the most commonly used stain is the modified quinine acid-fast stain, which can be applied to untreated feces and where Cryptosporidiae show up red against a blue background. Immunofluorescent stains are also commercially available. In duodenal biopsies, masses of Cryptosporidia can be seen adhering to the epithelial cells. Fluorescence image of Cryptosporidium parvum oocysts treated with diamidinophenolindole or DAPI, which stains the nucleus of each sporocyte within the oocyst. There are 4 stained nuclei in each oocyst. Cryptosporidium species in a fecal preparation from an HIV-positive patient with chronic diarrhea and less than 50 CD4 T cells per microliter. This is a Kinyoun stain. Cryptosporidium and Isospora belli in the same sample. Note the size difference. Nucleic acid amplification replaces staining methods because of greater sensitivity and specificity. Here is an example of a commercially available PCR test for Cryptosporidium parvum. The 435 base pair band is specific for C. parvum. Microsporidia are eukaryotes genetically related to fungi, compulsory intercellular symbionts. There are 150 genera and more than 1,000 species, a real zoo. Their pathogenicity was discovered 150 years ago in silkworms, but the first description of a human case dates from 1959, and the enterocytosome buonusi infection in HIV was discovered only in 1985. Note the tropism of the different species of enterocytozoae. Whereas Helm, Cuniculi, and Intestinalis can infect the eye and the lung in addition to the intestinal tract, Buonusi is limited to the gut. The infective form of Microsporidia is the environmentally resistant spore. The spore extrudes its polar tubule and injects the infective sporoplasm into the host cell through the tubule. Inside the cell, the sporoplasm undergoes extensive multiplication and matures into spores. This can occur either in the cytoplasm, for instance with E. buonusi, or inside a vacuole termed parasitophorous vacuole, for instance with E. intestinalis. During sporogamy, a thick wall is formed around the spore. When the spores completely fill the cytoplasm, the cell membrane ruptures and releases the spores to the surroundings. These free mature spores can infect new cells and thus continue the cycle. Electron micrograph of an E. buonusi spore. Red arrows indicate the double rows of polar tubule coils in cross-section, which characterize a mature spore. Scanning electron micrograph showing an eukaryotic cell bursting and releasing spores of encephalitosome helem to the extracellular medium. And finally, a scanning electron micrograph of a microsporidian spore with an extruded polytubule inserted into a eukaryotic cell. The spore injects the infective sporoplasms through its polar tubule. Duodenal epithelium with enterocytosome buonusii. The developmental stages between the enterocyte nuclei and the microvillus border include proliferate plasmodium, late sporogonial plasmodia, and mature spores. Electron microscopy of a duodenal biopsy in a patient with AIDS and chronic diarrhea showing enterocytes infected with encephalitosome intestinalis. And electron micrograph of an enterocytosome buonusi spore in stool. In advanced HIV infection and other diseases with severe immune suppression, for instance after bone marrow transplantation, Microsporidia can cause chronic diarrhea, keratitis and conjunctivitis, hepatitis and peritonitis, biliary tract disease, and urinary tract infection. In case reports also pneumonia, CNS infection, and disseminated infection. The diagnosis of microsporidiosis is usually established by examination of fecal samples or of intestinal biopsies. Microsporidia are difficult to distinguish from Cryptosporidia. The Giemsa stain or the modified trichrome stain, so-called Weber stain, may be used. Fluorescent antibody stains are also available. Electron microscopy is a possibility, and gene amplification by PCR. Microsporidia in bronchoalveolar lavage, Gram stain on the left, fungiflora on the right. E. buenusii spores in a fecal sample colored with a chromotrope stain, and on the right a Gram-stained urine showing intracellular clusters of encephalitozoon cuniculi. The differential diagnosis relies on differences in size, but the sizes of Microsporidium and Cryptosporidium overlap. Cystoisospora are clearly larger. Comparison of Isospora belli with a size of 15 to 20 microns and C. parvum with a size of around 5 microns. Another size comparison using Acrifluor, a commercially available acid-fast stain. Note that Isospora is now called Cystoisospora. Comparison of E. buenusii top and Encephalitozoon intestinalis on the right. Both samples stem from immunopressed patients with AIDS and were colored with a chromotrope Weber stain. At the bottom, a brown Ben tissue Gram stain of an intestinal biopsy with spores of E. buenusii. Extraintestinal infections with Microsporidiae include keratitis, encephalitis, and pneumonia. Punctate keratopathy in a patient with AIDS due to microsporidial infection. Chromotrope stained smear of a conjunctival swab in an HIV-infected patient with keratoconjunctivitis with an intracellular cluster of the Microsporidian encephalitozoon helem. T1-weighted magnetic resonance imaging showing multiple small contrast-enhancing, mostly ring-like, partly micronodular lesions in hippocampal, mesencephalic, and intracortical regions. Spores of the Microsporidian encephalitozoon cuniculi were detected in cerebrospinal fluid and in the urine sediment. Fumagillin is a veterinary drug that has been used for many years. At a dosage of 60 milligrams per day for 2 weeks, it showed excellent efficacy with moderate thrombocytopenia as the only notable side effects. Let us now turn to Giardia intestinalis, formerly called Lamblia. This pathologic agent causes waterborne outbreaks of acute diarrhea in immunocompetent people. Sexual transmission is possible, especially in men having sex with men. In the immunodeficient, it can cause chronic diarrhea. This would be true for HIV, sprue, common variable hypogammaglobulinemia, etc. There are 2 forms of Giardia, the trophozoites and the cysts. Only the environmentally resistant cysts are infectious. In the small intestine, the cysts give rise to two trophozoites by longitudinal fission, and in the colon, the trophozoites transform into cysts again and are excreted. Pictures 1 and 2 show Giardia cysts with an iron hematoxylin stain, and picture 3 the same in a wet mount by phase contrast. Cysts contain 2 to 4 nuclei. Picture 4 contains larger Giardia and smaller Cryptosporidium cysts in comparison. 3 trophozoites of G. lamblia intestinalis, colored with trichrome or iron hematoxylin stains. And if it looks at you, it's Giardia. Masses of Giardia intestinalis can be seen in biopsy and have been compared to autumn leaves. Giardia trophozoites as seen in the electron microscope, and on the right, an artist's conception. As is true for Cryptosporidia and Microsporidia, PCR tests are available for Giardiasis. The characteristic band here has a size of 183 base pairs. Giardiasis is usually treated in non-immunosuppressed hosts by 250 milligrams thrice daily of metronidazole for 5 days. The treatment needs to be prolonged in immune-suppressed patients. Thank you for watching, and thanks in particular to Rainer Weber for his many pictures. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.